My name is Sandeep Gill. I am the Quality and Knowledge Translation Manager at AFTO. Thank you everyone for joining us today for the webinar titled Supporting Older Supporting Older Persons at Home, Learning and Collaboration During the COVID-19 Pandemic and Beyond. With us, I have our colleagues from Provincial Geriatrics Leadership Ontario, and I will hand it over to them just in a few seconds for introductions, but I just wanted to go over some housekeeping. This webinar is being recorded, and we will be sharing the recording within a few business days once we're done today, and the slides will also be sent out as well. So keep an eye out for your emails. If you've post-webinar, we'll be sending those out. And for the Q&A, you can send your questions into the Q&A box at the bottom in the black bar. And if there's any comments, you can put them into the chat box as well. I will be facilitating these at the end of the webinar. And with that, I will hand it over to my colleagues. I believe I'll hand it over to Kelly. Yep.
Hello, everybody. Thank you so much for letting us come and present Sandeep. We're really delighted to be sharing this airtime with our colleagues at AFTO. My name is Kelly Kay, and I'm not on the front slide. I'll tell you why in a moment. I'm the Executive Director of Provincial Geriatrics Leadership Ontario, and we're having a little bit of a pinch hit today. Our colleague, Dr. Benjamin, had an unfortunate accident. She's okay, but we're filling in, and my colleague Adam and I will be assisting Dr. Kevin Young today with the presentation. So why don't we launch in? Adam is managing slides from our end. So Adam's going to take us through. We've got the disclosures here that are relevant to our initial planned speakers. And just by way of disclosure, both Adam and I are employees of Provincial Geriatrics Leadership Ontario. We'll go on to just share the learning objectives. What we're hoping to share with you today and exchange with you today is we want to tell you a little bit about who we are as one of your regional partners that you can draw on in your work. We're partners at the provincial level with AFTO and in many ways at the local level with our colleagues who work in family health teams and CHCs and other models of primary care. And it's actually a real personal pleasure for me to return. I come from a family health team world some time ago, so it's a real pleasure for me to return and speak with you. We're also going to share some experiences of care in the community and what we've learned about working with older adults during the COVID experience, and I hope it will resonate with you. And we've got some resources to share with you to be helpful in the care of community dwelling older adults. So our agenda for today is really just beginning with a quick overview. We'll share some concepts and models that are emerging. And as you are engaging with your work as part of the broader OHT landscape, that might be helpful to you. We've got a few case studies and then a few tools and resources to share. So why don't we launch in? So let me just start with a bit of an overview of Provincial Geriatrics Leadership Ontario. We're the infrastructure for clinical geriatrics care, and we're funded by the Ministry of Health. And we're designed to coordinate the perspectives across clinical geriatric services. And so that means care of the elderly, geriatric medicine, geriatric psychiatry, seniors mental health, members of the interprofessional geriatric team. And our intention is to improve care for the older adult across the continuum of care, many of whom are part of your practice too. Our structure is based on the framework for collective impact, not too dissimilar to a role that AFTO plays with you in that we help to provide that backbone for a common vision of older adult services. And PGLO is focused on three strategic priorities: driving clinical excellence, building capacity across the system, and advancing seniors' health policy. So a little bit more about this infrastructure, just in case you're unaware. Across Ontario, there are about 2,500 health professionals that work in about 450 programs and services specifically focused around this population, this older adult population living with complex health concerns. And you may know them by the name of specialized geriatric services. The role of those services, they may be organized locally or regionally. You may be aware of some in your own communities. And these teams and services provide direct support or share in supporting care for people who have a physical, mental, social, spiritual issues related to care that, that the older adult might need to live well. And we work to build system-wide capacity through collaborative planning and education to influence the care of all older adults. So when you think about the sort of the degrees of need, we've just got a little picture on the right-hand side that kind of shows how we envision working within a system, knowing that for many of the people that we're encountering, you're also encountering them as well. The next slide tells you just a little bit more of the full array. So on the left-hand side, us being the provincial entity, and in the middle are those organizations you may have encountered before that deliver direct services, but also are responsible for some of the planning of services related to older persons care and older people living with complexity specifically. And at a local level, we're working to provide direct care to individuals in concert with you in primary care, as well as working to support the emerging Ontario health teams. So we're going to talk a bit about integrated care, some concepts and current models, and some work we've done recently. And just on the next slide, I want to introduce you to some work we've done to think through the elements of integrated care. And I know it's a little teeny tiny on your screen here, but we do have a scoping review on our website, and there'll be links provided in the materials that come out to you afterwards. So what we did is we looked in the literature to try to understand how best to describe the aspects or elements of integrated care for older adults. We looked across the literature at models and frameworks and identified 13 design elements. These can be really important as you think about care provision within your setting and as you enter into conversations with OHTs, designing around pathways for people who live with complexity, particularly the older adult. And for us, it's also part of an overall project to identify indicators specifically relevant to older persons' care. We're also inviting participation. So if this is something of interest to you, do follow up with us, because we are looking for primary care input into a consensus process that will start in April, and we'll be looking for input around indicators. We're trying to answer the question of what ought we be collecting, not simply what's available in administrative data sets or elsewhere, because I think we know that the system isn't really fully designed around the needs of the older adult, and so we've got some work to do. And just to familiarize you with a whole range of designs and supports are available. I know there's tons of frameworks out there. I've heard tell that that the feeling amongst the OHTs and our colleagues in primary care is it's often like drinking from a fire hose. There's so much out there, what framework relates to what. So we've tried to put it all together here for you. You may be familiar with senior-friendly care. The design elements also are a part of that sort of overarching framing of older persons care. And then you may be familiar with this full array of services and tools and resources on the right-hand side. Behavioral supports now has some community-based support. Jerry MedRisk is a resource that is available, and Adam will be speaking more about that. Of the work of the Ontario Palliative Care Network and the Rehab Care Alliance. And then there's many standards developed by Ontario Health Quality that are pertinent to older persons care. So if you haven't seen all of those, do let us know and we can connect you, or you can hunt them out for yourselves as well. And now we're just going to go in and talk a little bit about some case studies, beginning with what we're trying to illustrate here are some opportunities for collaboration in the care of older adult that are sort of cross-sectoral. The first one is one that I'll speak to, and then I'm going to turn things over to my colleague, Adam. And this is an example of a connection between a community paramedicine and a specialized geriatric team. This particular example arose in Haliburton County. And this was an effort between Haliburton County Paramedic Service and Haliburton Highlands Health Services, as well as the local geriatric service called the Geriatric Assessment and Intervention, or GAIN team. And the reason why we're highlighting community paramedicine is because there's also an effort afoot right now to move forward with an expansion to community paramedicine. And there'll be lots of intersection points with primary care. And if you haven't been connected already, I'm sure you'll be tapped on the shoulder. So just wanted to share an example here where there are connection points between services that you could look to. This one this service has grown to include 2 paramedics, and Haliburton is a small rural community. So 2 paramedics, and one has been recently funded through some new funding called the High Intensity Supports at Home funding. This paramedic receives referrals both from the team and from the broader community, and is a conduit between the individual in their own home and primary care, as well as specialized geriatrics. They participate in the case reviews and care planning and the implementation of the care plan. And in this example, the community paramedic is carrying about 60 active clients, really focused around those people living with medical fragility in the community, seeing about 4 to 6 in-home visits in a day. And I wonder if you may have been experiencing this in your own practice, that there's a real push from the older adults to start to receive more and more care in their homes, particularly during the pandemic. And I think that this is something that's going to be a continued ask going forward. For those who may be connected to paramedics, we've sort of seen that the ideal paramedic is a person with really significant experience and well-developed assessment skills and patience, and somebody who's able to take the time to talk and understand the whole picture. And that's certainly what that older adult in the community needs, a broad view of all things that might be relevant to keeping them living well at home. I'm going to turn things over to Adam now. He's going to take you through some other examples, and then we'll move on to Dr. Kevin Young, our colleague.
Thanks very much, Kelly. And so I'm going to take over with another case example, and just to flag as well, Sandeep was very good to send us your questions in advance. So you'll notice our case studies are going to be pretty rural example heavy. That doesn't mean that folks in urban areas or remote areas couldn't think about some of these solutions as well in terms of their own planning and system connections. But we really did want to answer a few of the questions that came in around what are some supports that are either available within rural or access kind of across the province. So I'm going to talk about something a little bit different called Geri MedRisk. So Geri MedRisk is an interdisciplinary consult service, which clinicians for Geri MedRisk, which would include pharmacists, nurse practitioners, PAs, or physicians can access. And the good news is that you can access Geri MedRisk across the province. So it is an interprofessional group of folks who answer consult questions related to medical complexity. So it is a group that includes geriatric pharmacy, geriatric medicine, geriatric psychiatry, as well as clinical pharmacology. And unlike some other e-consult services, though Geri MedRisk is available by fax as well as by phone, you can also access them on e-consult. They do more of the integrated consult. So all 4 of the specialists that I spoke about come together, and you can see they look at medication, mental health, physical health concerns as well. In a number of regions, Geri MedRisk is also part of the specialized geriatric service central intake referral. As I mentioned, you can also access them through e-consult, phone, or fax. One of the really great things when speaking to primary care about this service is number one, it's 100% funded by the ministry. So there's no cost, there's kind of no additional technology that you need to be taking on. And I think most importantly, when speaking with folks in primary care, this is a consult service, not a referral. So the primary care team the MRP and the team-based care doesn't change. These are recommendations that come back to you, and they do look holistically at folks. We also receive some questions, folks asking about people who are experiencing isolation, people who are experiencing multiple conditions, folks who may not have regular access because of their geography or their own barriers around transportation and time and money. This is the kind of service that can provide an integrated consult regardless of where you are within the province, and their median consult time is response time is within 5 days. So as where sometimes your patients may be waiting months to see somebody who is outside of a fit, for example, they can do at least the management and sometimes avoid hospital visits, sometimes also avoid assessments, and help people to live at home for longer and more safely. In addition, with every integrated consult note that goes back to the primary care provider, there are also educational materials. So Geri MedRisk has created a whole suite of drug information summaries that are specifically targeted to the older adult. So folks in primary care can review those and think about those for specific medications for next time. So it's not just the one and done consult, but kind of some ongoing education that can be there as well. And this is their process. And just to flag as well, in terms of clinical questions, these are the most asked questions here. Excuse me, in the word cloud that folks are getting. So I know a number of people are asking about falls and mobility. That's a type of consult question that Jerry Medris can support. Other pieces around medication management, behavioral and psychological symptoms of dementia, anxiety, polypharmacy, and you can see a really strong mix here between mental health as well as physical health. And that's, once again, these are not kind of one question about deprescribing all the time. Sometimes it could actually include 4 or 5 different elements that are here that are all part of an integrated consult that comes back. So we wanted to flag this as a good example of integrated care that supports, complements, and does not replace any of the work that happens in primary care as well. And now I'm going to pass it over to my colleague, Dr. Young, for the rest of the presentation.
That's great. Thanks for that introduction. So I see several of my colleagues from the Kuching Family Health team that are on the line, and so you'll recognize this. And I'm putting up this sort of figure as an example of, you know, what is possible when you collaborate between different organizations and you really sort of think about sort of breaking down a lot of the barriers that have traditionally been there. This concept continues to be a work in progress, and we're constantly tweaking it and changing it. And so this slide will look different from one week to the next as we put it up. But I thought it was important just to sort of talk about the concept and just to highlight what's possible. So starting at the top of the figure here, you know, when a primary care provider sort of recognizes that they have a patient that needs some additional assistance, then they make that request. If it's just assistance for what are sort of core senior services that may be available in the community, then that can just sort of happen directly, and they can just refer directly, and that can happen. But in many cases, these individuals will be a little bit more frail. They'll have health issues that will be in multiple sort of areas, and they'll need sort of a bit of a deeper dive to sort of figure out what's going on and to figure out what resources would be appropriate and to help support whatever is going on with them. So in which case then they're referred to what we call internally the specialized geriatric program. And we're continuously sort of changing how this happens, because there was some duplication and some overlap with the regional program and what we had developed locally. But what we're sort of working on right now is that those patients that were appropriate for this service, which you know, are often those with frailty, we often define them as according to the clinical frailty scale that sort of looks at you know, how many different, like how somebody's functioning, and you know, how many different medical comorbidities they have, and we sort of, you know, based on that decide whether or not they may be, you know, potentially eligible for some service. But once that referral is received, then there's a pre-assessment that's done, and we're working towards this pre-assessment being done sort of at a centralized location. So after that pre-assessment's done, this is a phone call generally to the patient and or their caregivers, and we sort of assign based on that sort of, you know, what priority do we need to see the patient. We also sort of set up front some expectations of, you know, what we hope to accomplish during the time that we're interfacing with that patient, just so that it's very clear that we're working together with the primary care provider and not trying to take over care, and it's meant to be complementary. And we really want the experience to seem to the patient like it's sort of seamless and it's sort of an add-on, but not sort of a taking over of the care. And sometimes there's the ability right from that very pre-assessment stage to right away assess that there's some resources that may be needed. For example, home care or Meals on Wheels, or you know, referrals to some private services that can just really help to mitigate some of the things that are going on with that patient right in that moment. From there, if it's not clear what the next steps are, or if there's more discussion that's required, then it can go to a team huddle. That team huddle is more and more starting to involve now the regional program, which is where we have access to geriatric psychiatry. And so sometimes we just say, you know what, there's more of a psychiatric issue here than a medical issue. And so we may refer directly to geriatric psychiatry from that. There may be questions that need to be answered that are more timely or more sort of medication related. And so we may pull in Geri MedRisk, which Adam just presented. And so that can be really helpful just to get somebody through to the right resource sort of as quickly as possible. And then either sort of simultaneously with the geriatric psychiatry, or if that's not required, then they can then go on to have what we call a comprehensive geriatric assessment. So this is just essentially done in this model in conjunction with the nurse and with the OT, but there are different individuals that can do it, and there's different models of how this can be done, but it's a very comprehensive look at all of the factors that would be affecting an individual's health, including everything from their medical issues right through to what support systems they have, what their current sort of care plans look like, what additional resources we need to pull in, and whether the housing is appropriate, sort of financial resources. We pull in sort of as many different aspects as we can so that we can fully understand what's going on with that patient. Once we've had a chance to do that sort of deeper geriatric assessment, sometimes it's only at this stage we realize that we need to pull in geriatric psychiatry, so they can be pulled in as necessary, or sometimes they've already been involved. But more importantly, we then have a whole team of other individuals that can also provide care to that individual. So it may be, physiotherapists or system navigators, social workers, pharmacists, the list goes on and on. There's some outpatient exercise programs that can be involved. There's a geriatric NP. So we can then form a team around that patient, which is specific to what that patient's needs are and might look different from one patient to the next. Now, the important part on the left-hand side here is that the primary care provider continues to be part of the patient's care at all of these stages, and we're in no way sort of cutting them out of the care. So once all of the team is sort of assembled, the assessment's been done, there's some sort of treatment plan or care plan that's been developed, so that we then sort of help to enact that plan in as many ways as possible, and start to think about, what would a transition back to the primary care provider being sort of the first and most responsible sort of person that that individual would interface with. Maybe it's transitioning instead sort of to long-term care. Maybe there's other community resources that we need to pull in, or maybe there's other consults that we need, but that would all sort of happen as part of that transition. And this more intense sort of assessment and treatment plan would be done for a limited period of time, and then hopefully integrated into sort of their normal care. So if we can have the next slide. So this is just one example of what we were able to accomplish because this model was in place. So when COVID first started, there was a collaboration between the Couchiching Family Health Team, the Family Health Organization, the Soldiers Memorial Hospital, which is the local hospital, as well as the Regional Specialized Geriatric Services Program. And we very quickly sort of realized that seniors, older adults would be coming to assessment centers, and some of them, would be isolated in their communities or wouldn't necessarily have the follow-up. We could have individuals there that were COVID positive, but didn't have access to resources in order to support them at home, or could have sort of changing resources. So we set up very quickly an ability to do a comprehensive wellness check for any patients that had come into the assessment centers. So this was done in collaboration with all of the individuals above, and in fact this tool was ultimately spread and used throughout the province. But we were identifying things like isolation, lack of resources, caregiver stress, acute medical concerns. And then when those were identified, then the older adults could be connected with local resources. Primary care providers were sort of notified, so that they were aware that their patient had been in the assessment center, and they were aware of sort of what some of these complex needs were and what was being done, and so that they could be involved and they could sort of add their perspective and their resource to everything that was being done. And if they didn't have a primary care provider, then then we tried to roster them to a physician that was able to provide that service. So over the first 3 months, almost 150 wellness checks were done. About a third of them were referred for follow-up and sort of connection with additional resources. So clearly sort of paid off. So at the moment, this process continues, wellness calls continue, and it's really sort of ensured that patients get what they need sort of in a timely fashion. I will say that the team that was involved in making this did win a Bright Lights Award from AFTO. So this is some really quality work that was done by them. Next slide. So this is now changing gears a little bit, looking at what are some of the other things that PGLO does, and how can we sort of provide some supports to all of the different programs that are out there. So as many are aware, there's a cognitive tool, the MOCA, that's used quite frequently in the assessment of individuals with cognitive impairment. As training has become more mandatory and has a cost associated with it, then we wanted to look and sort of see what are some alternatives to that. And there may be some cases where that's the best alternative, but there may be other cases where there's some equally good or perhaps even better alternatives. And so a small group of individuals throughout the province met and went through all of the screening tests that are out there to look for cognitive impairment, and used a very unique way of sort of identifying them based on how long it takes for the study to be or for the test to be done, how sensitive and specific is that study. So in other words, how much are you likely to get the answer that you're looking for, as well as whether they cost money and whether they're freely available. And so now if you look at this particular publication, you'll see that there's a whole array of resources out there that you can use. Now this is all being done for cognitive screening, which is really what the MOCA was designed for, and to pick up cognitive impairment. Some of these other tools are also used for assessing patients with cognition, and that's a little bit of a different question, which we're currently continuing to work on, but I think this is very useful. Next slide. And in fact, it was so useful that the American Geriatric Society worked with us to come up with a mobile toolkit where all of the tests that are on there are available sort of in a summary fashion, and you can go to that website and you can click on it and you can see all of the highlights of the various tests that are out there, and when you might use them and when you might not, and what some of the advantages and disadvantages are. So there's a really practical sort of way of using that information. Next slide. And then as the next part of the presentation, I just want to sort of highlight a small sampling of some of the resources that may be relevant. We have a lot of resources, and it would take more than this 1 hour to go through everything that's available. So I really encourage you to look at our website and sort of see what else is there might be relevant, but we just tried to pick some that may be particularly of interest to this audience. Next slide. So as I mentioned, within days, a clinical screening tool was developed and disseminated to really help at the beginning of COVID with that rapid shift to telephone-based care for older adults. That assessment tool was done in part because of the connection with the assessment centers and wanting to reach out and do those assessments, but it also helped us to keep track of patients that were in geriatric clinics. There was input from geriatric programs from around the province, and that clinical tool is linked to from this slide, and you can see the latest version of it there, and you can take it and adopt it for your own purposes, but we found it to be incredibly useful and very sensitive at picking up the needs of older adults. As you'll remember, towards the beginning of the pandemic, and it has continued to haunt us ever since then, but there was a great tension between trying to protect long-term care homes from outbreaks, and we've seen the just the decimation that can happen after COVID outbreaks in those homes. But on the other side, family presence in long-term care homes was something that was restricted quite significantly at the beginning and continues to be quite restricted. And so we produced a position paper that had authors throughout various physicians and other clinicians that are connected with PGLO, as well as clinicians across Canada and from different organizations. And we were able to sort of, really help balance, the needs of patients to not be isolated and to be socially connected with their need to also be protected from COVID. And so if that's something that you're grappling with, then you might want to sort of look at that as an example. We also developed a virtual care decision tool to really walk through all of the aspects of, whether or not it's appropriate to assess an older adult virtually versus not virtually. And obviously there's two sides to that coin. On one hand, a virtual assessment may be better than no assessment at all, and there may be a need to do a comprehensive geriatric assessment and really understand that client's needs and really be able to dig down and do that. However, it may not be as comprehensive as an in-office visit. You might miss things. There's sort of like everything in life, a good and a bad side to it. And so it really helps you walk through, what would the benefits be versus what would the risks be, and should you go forward with a virtual care assessment versus sort of an in-house assessment. And so again, there's lots of good thinking there. And I think, if that's something that you continue to grapple with, and I think we all do, then hopefully that would be of use. The last thing is that there's a suite of resources for older adults who might have questions or be hesitant about a vaccination. We've seen a lot of questions about vaccination. Vaccinations are changing literally by the day and by the hour. Every time I present on vaccinations, I literally have to say, like, this is up to date as of like an hour ago, but by the time I finish this presentation, it might be different. But in any case, there's some resources there on the website that answer a lot of the questions that are specific to older adults. Sort of think about it from the lens of older adults, and hopefully again, sort of useful from that perspective. Next slide. We've had an international town hall sort of right near the beginning of the pandemic where we sort of looked at lessons learned on how to support long-term care. As you know, the Canadian experience was very different from the international experience, and so it's very important to learn from some of those international experts, and there's a lot of learnings that we have from that, so you can see the report linked to there. We curated now a repository of more than 100 COVID-19 resources that sort of help you to focus on the care of the older adult sort of in the era of COVID-19. So look at our repository. There's many other things in our repository that aren't COVID related, and so that number is growing exponentially, and hopefully there's some useful materials there, but specifically there's some good COVID materials. We also have had a webinar series on chronic disease management and long-term care that was specific to issues that came up with COVID-19 or lack of access to some of the traditional resources, because of COVID-19. And so there's, one on diabetes management and one on heart failure management by clinicians that are experts in that area. So I encourage you to look at those webinar series if that's of interest. Next slide. There's several other projects that we've undertaken and supported through the years. One of my favorites is the support for caregivers. I don't think we can ever give caregivers enough support, and yet, the traditional way that courses are offered, it takes them away from their loved one. It's a huge commitment of time. There often aren't resources to be able to spell them off, and so there's some strategies here that can be helpful. One is a handbook that can really support sort of resilience and independence and quality of life for caregivers, and it's available in a multitude of languages, and it's available for free, so you can link to it here. We have a limited number of those that are sort of published in print just because of cost, but please take the handbook and use it and reprint it and share it as you see fit. And then there's the actual caregiver strategy course, which was co-designed with caregivers, really takes into account, what caregivers are looking for, what questions they're asking, what information they need. You can see some of the topics listed below here, but they're very relevant topics to caregivers. And the course is offered on our website we're in the process of sort of continuously sort of modifying how that's offered in order to meet the needs of individuals. And so we're opening it up as of tomorrow for our next offering of the course, and the course will be left open until the end of May. You can work through the course at your own pace. You can do it asynchronously. There are moderators that are available to answer questions, and you can dialogue with other individuals that are sort of taking the course at the same time. But it is internet based, and it can be done at your own pace, and it can be done after hours or whenever a caregiver has time. So please spread the word and have people sign up for that. There's no cost to that course at all. It was all designed and funded through a grant. Next slide. We also want to continue to build supports and capacity for older adults. And so, one project that we collectively took on amongst many of the specialized geriatric services was to create a competency framework where one can sort of self-assess and see whether or not whether or not there's areas where you might want to supplement your knowledge and your skills in terms of being able to comprehensively assess an older adult. And then there's links to resources that you can use in order to accomplish that, and suggestions, sort of paid and not paid, of how to fill some of those gaps. And that's also offered through a mobile compendium in a mobile-friendly website that you can access as well. So please take advantage of that, and hopefully really help to identify sort of your own knowledge gaps and help you with your own training. And please use that, because a lot of work and effort went into it. I think it's absolutely fabulous. Next slide. So that's sort of a really quick snapshot of a lot of work. We've deliberately timed this presentation to leave lots of questions, for you to ask us and to have a little bit of a dialogue. But we'd love for you to share your experiences with us about, what worked during the pandemic, what was problematic, what changes have you made that you would keep. We're also sort of looking for your input via a survey, and there's a link there, and it's just to better understand the scope of services that may be required by older adults, and to sort of inform some of the planning and the activities locally and with OHTs as well as regionally and provincially. And so having this opportunity to hear from you what's on your mind is invaluable for us to continue to do our work effectively and to bring things that are relevant and useful. So with that, I will pass it back to our moderators, and happy to take whatever questions are coming up. So thank you very much. And the survey has been also put into the chat, so the link will be there in the slides when they come out, but please also copy the link down from the chat, and we'd love to hear your comments. So thank you. Sandeep, over to you.
I think if I could just jump in really quickly there. Sorry, Sandeep. Just to reiterate what Kevin said, all of the links that we've provided here will be in the PDF version of the deck that everyone gets, in case you missed that at the beginning. Everything that we're linking to is freely available. Feel free to share, and also free to use. And I just want to off the bat answer a couple of questions that we had received in advance. So one, and I don't want to miss this, that's why I want to bring it up first. A number of folks did ask about mental health supports in general, specifically about social isolation. You'll see in the appendix of the deck, Ontario Health actually put together a helpful placemat that has buttons that you can click that will connect you to mental health resources that are in your area, specifically in a virtual sense that people can access. So I did want to speak to that as well. And in addition to what Kevin said around a couple of our resources, which are in a number of languages, some of you also asked about COVID-19 resources that are in a number of languages. And I think the best place to start with that is actually Public Health Ontario. The vast majority of their resources specifically on COVID-19 are translated into 30 different languages. Sorry, Sandy. Didn't mean to scoop you on the questions.
No worries, thank you. So I have put the survey link into the chat, but we will also send it within the email as well. And as Adam mentioned, we'll send the PDF. So if anyone has any questions, you can type them into the Q&A or chat, and we can ask them now. I have a few written down so far, and then, maybe some more will start flowing in as well. So for the initial piece, we had started with the Jerry Med Risk tool, and I think folks, I guess it's linked into the PDF, but they were wondering where it was found, or where the tool is housed, if it's like a website that they have to go to that's external from their EMR.
So the complicated answer is it depends on your area, but the general answer is yes, you do have to be out of your EMR for some instances. So you can access, if you are already registered and using eConsult, then you can access Jerry MedRisk under, it's its own specialty group. So you can just do it that way. Alternatively, 9 to 5, Monday to Friday, you can call and initiate a consult that way. And you can also send something to their fax number, and that's running 24 hours. So the website is jerrymedrisk.com. Like I said, it's all funded by the ministry, like the other pieces that we spoke about. So there's no cost to the provider. And typically then kind of the answer to the consult, folks would put it back into their EMR, because as I'm sure everybody on this call knows, Ontario is just the land of EMR pilots, and everybody has something different. So they may have access, but I don't want to promise anything and say it's probably going to be the old-fashioned way.
Okay. And then, so since you are saying it's funded, sometimes I think like a follow-up question came up, sometimes things are funded in a specific region within Ontario. Is this funded to, like, throughout the whole province?
Yes, so fortunately, Jerry MedRisk has direct funding from the Ministry of Health to provide consults regardless of care setting and regardless of location.
Okay, great. And then the next question that we had was for the Couchiching Family Health team. Again, congrats to the team, and they're doing such great work. Thank you for mentioning the Bright Lights Award, Kevin. So one of the questions came up is, I don't know if you'll know the answer. I think I know the answer a little bit, but one of the questions that came up was, how was the vulnerable population identified in terms of the list for who they were outreaching to?
Yeah, so this is a little bit of a work in progress. Right now, the vulnerable population is really identified through the primary care provider, who sort of recognizes that there's some additional needs and will make that referral. As we're pulling in the regional program, then the regional program uses the clinical frailty scale. So this is a scale, depending which version you use, between sort of 1 and 7 or 1 and 9. We choose sort of patients that are between 4 and 6. So this is sort of like starting to be slowed down by disease, starting to rely on others, but not sort of 100% dependent on all of their needs of others. So it's that sort of group where there starts to be some vulnerability, but it's not so much that that they're always going to be in a location that's requiring sort of round the clock care and that type of thing. And the reason for focusing on that is that it just helps to identify, or just helps to sort of narrow the window of where we can potentially reverse some of the frailty, where we can sort of make sure that there's appropriate resources. It often flags a population that's going through a transition, and so we can sort of help during that transition. There are other initiatives across the province that aren't connected to the Couchiching Family Health team, but using RAI data in order to look and identify vulnerable populations. And so there's lots of work on that. There are other methods that I've heard from some other family health teams where they're actually using some criteria to look through the records and try to sort of case find, to identify more of those vulnerable adults. In the Couchiching experience, we've had so many identified already that we're always sort of playing catch up with the waiting list, and so we've never gotten to the point of sort of going out and searching for vulnerable adults. But of course, that leaves the question of are there people out there that we should be helping and we're not? And one another unique way was just and it's the reason why it was conceived of. When we started then sort of reaching out to individuals that had gone to the assessment centers, that the plan there was exactly that very thing, was to sort of case find, like, who might be some vulnerable individuals that we may not even know about in the community. And that may be the only place during COVID that they can reach out to, because they're feeling so isolated. And so that's been very successful as well in sort of identifying some of those populations. But and feel free to add in, Sandeep, if you had some additional thoughts. It sounded like you might.
No, what I've heard mainly from our teams is just the EMR queries that they're running. I know ECE has developed one for chronic diseases now for the vaccine rollout in terms of identifying the population. So I know from there, but other than that, I know teams just developed their personalized queries depending on the primary care provider's asks and identifying. From the frailty tool, then would you identify a list of seniors and then from there I assess them from the frailty tool, or would that happen within the query?
So we have been generally applying the clinical frailty tool after the referrals have come to us, but I think it would be brilliant to get to a point where primary care providers are starting to think about that and starting to use that as a tool to sort of say, oh, okay, actually, I'm starting to notice that there's increasing frailty here. Maybe it's a time to start, to make those links. And so we're using that language in the consults back. We're trying to, make that sort of a familiar concept for people. And it's very, very simple to apply. It's really just like a description of people that are at different stages of frailty, and you just sort of knowing your patient sort of choose where you think they fall into that scale. But it can be applied in like a matter of, once you're familiar with it, a matter of like a few seconds with a little bit of knowledge. And so I think that will help us to speak the same language and to be identifying people and to get people thinking about what other needs might be present when you're seeing somebody in a busy office in a busy family health team setting.
Thank you. And then the other question I have here is around the caregiver course. I know you mentioned the next one is going live. They were wondering, do they need to attend it live in terms of a time that it's happening, or can they listen to a recording but still get in contact with the moderator if they have any questions? Yeah,
so great. And maybe I didn't explain that well, so I'm glad you came back to it. So the course is all online. If any components that are videos are all pre-recorded, but there's also slides that they work through, which are basically just websites that change from, the content from one slide to the next. They link to the videos where videos are required. And then the moderated sessions are all done through chat. So you just type in your question or your comments and then others can answer it. So there's no specific times that people need to come. It's all completely online at your own time, at your own pace. You can read all of the modules in one day if you want, or you can spread it out over the entire 2-month period. The activities as you go through do encourage sort of, making comments and contributing to sort of a dialogue that would take place between all of the members that are taking the course, but it's not mandatory, but it's sort of built right into the content. So that'll just be kind of a natural part of taking the course and being able to ask questions and speak with other people sort of virtually by chat. It's moderated just to make sure that it's a safe place for people. If there's content that's not appropriate, then we can sort of modify it, and just make sure that, if people are needing more help or different kind of help than that course can give, that, we can quickly identify that and make sure that, others are aware of that need.
Thank you. And then I have one more question, but I just want to encourage folks that you can type into the chat to share your experiences or any questions that you have. And I do have a poll before you guys, log off. But the one question that I have as well, I think it might be just a little, maybe it's just a confusion on my end as well in terms of answering, but the competency framework, the way you described it, it was for the team to see where there's gaps that they would need learning for, but then there's also a piece that's written on the slide around support for interprofessional teams conducting the comprehensive geriatric assessment. So would it be to help support the assessment and guidance on how they should be doing this assessment? And is that assessment like the forms that are associated with that integrated into the EMR as well?
So I'll take a first stab at that, and then Adam, feel free to sort of add in. But so much of it is designed to break up. Actually, I'm going to start before I say that. I'm going to start by saying that there's many ways to do a comprehensive geriatric assessment as there are people that are doing it, and it's a very individualized type of assessment. And really, it's not even just an assessment. The concept is that you're doing everything from understanding all of the needs of the patient and reviewing all of the medical pieces right through to, you know, the linkages with other organizations, the care plan, the diagnosis, the entire thing would be encompassed in that assessment. And so what the competency framework does is it breaks up sort of into components some of the very common areas that most people would do as part of a comprehensive assessment. It allows you to self-assess sort of what your own knowledge and your own skills are in each of those sort of component areas. And then so there's a sort of a self-assessment quiz almost that you can take and then sort of identify where your own gaps may be or where a team's gaps may be. And then there's a second document that that's part of the whole compendium that then allows you to take those gaps and to link to, you know, resources that would give you further education or further sort of knowledge in those areas so that you can sort of come up with a learning plan and essentially sort of work independently or together as a team in order to sort of fill that gap. So I don't know, Adam, do you want to add anything to that?
Not really, just to underscore what you were saying, Kevin, around the team piece, that the resources, you know, as much as possible are targeted towards, okay, a team could learn this together, you could do this together and leverage each other's skills, as opposed to leaning more towards the idea of like, okay, social workers go off and do this, and PTs, this is what you should be thinking about. The idea of the competency framework and the mobile compendium is also that the learning and development itself will be team-based and not just this is what everybody's role is.
And some of the resources that are there are paid resources, but we made a real effort to make sure that in every area that there was some non-paid resources, and we found the best quality ones out there. In many cases, the non-paid resources are as good or better than the paid resources, but there's a few areas where you know, the paid resources are a little bit better, but we've listed them all so that people sort of, you know, so even if you don't have a budget for this, it's still very useful and very accessible. And we've had tremendous feedback about, you know, how much of a team building exercise that it can be, just because the team is learning together and thinking about these things together. And it's almost, you know, one of those things where the knowledge is important, but the process of gaining that knowledge together as a team is almost more important. So it's useful in both aspects.
Okay. Thank you. I am going to just launch a poll that we do at the end of all of our knowledge translation webinars, just to see some general feedback, so folks can do that right now. But I just wanted to take this opportunity as well to thank Kevin and Adam and Kelly for your presentation today and your support on this webinar. I know we have a few more minutes. If anybody has any questions, you can type them into the chat. Other than that, please do fill out the poll. It does really help us with our planning moving forward. And thank you so much for joining us today. Is there anything else, Kevin or Adam, that you wanted to add?
Nothing from my perspective. It was great to have this opportunity. And, you know, as we said throughout the whole presentation, this was just meant to be a sampling and an overview of what we do, but go to our website. There's a lot more resources. Reach out to us if you have other ideas. We're just hoping to get the juices flowing and people sort of thinking about working collaboratively. And I would just add that, you know, one of, you know, in the examples that we've given, Jerry Medris, the Kuching example, many others, you know, one of the real themes of our office is bringing together different subspecialties. So geriatric medicine, geriatric psychiatry, care of the elderly physicians, really sort of figuring out how we can work together, how we can be collaborative, how we can build resources together. We really see it as our joint mission to take good care of older adults and to help sort of develop those networks and to make sure that OHTs are able to sort of do that in an effective way. And so, so I really encourage you in your own areas to think about how to, you know, how to increase that collaboration, how to increase those linkages between those different areas, because we found that to be incredibly powerful. And it's actually what our whole office is founded on, is that principle of, you know, those specialties that may not traditionally work together, but all coming together and all rowing in the same direction. So Adam, anything from you?
I would just say, I mean, I can't really top that, but if folks do want to reach out, you can see the email at the bottom of the slide, info@rgpo.ca. That goes right to me. So if you have questions for any of us in terms of what we talked about today, some other things that you think you heard, some other things you think about later, very much happy to connect and continue the conversation in any way that we can help. And thank you very much for the opportunity to present.
Thank you. Thank you, everyone. Have a great day.
Bye-bye.
Bye.